As I can see, the new participants keep joining on and on, so we'll have to make a start. And would like to remind you here again that we carry on with the round of our lectures is the European experience of antimicrobials administration and also the IPC process, so perspectives of Ukraine, and this round of the webinars, so would have been short-lived and inconceivable. So, but for our unfailing support from the European, from the colleagues of the CDC, American CDC ICAP project from the University of Columbia, and also UKIC, and so who come around and share their valuable experience. So that is why I would like to ask you all to sign up for it and to keep abreast of all the announcements, because carry on with this round of the webinar since last December, and the previous recordings of the workshops uploaded to the UPHC website, and this recording will also come along on the UPHC website, and you would like to carry on well until August, so please stay tuned and get down to know this very valuable and useful knowledge that our counterparts and colleagues come around and share with us, and for this we're very thankful to them. And the lecture this afternoon to be devoted to the catheter-associated bloodstream infections and infections in the bloodstream. So, and this important topic to be presented by Elisabeth Presterl. So she is microbiologist. She is in charge of the School of BC and also hospital-based epidemiology in the Vienna University, and she is very experienced. She's very skillful in so far as the infectious disease and hygiene and clinical microbiology is concerned. So prior we make a start to this lecture, so we would like really to run you down the agenda. So this event shall last as long as 1 hour, and after Elisabeth is through with her lecture, we'll be able to ask her some questions. And for this purpose, please feel free to go ahead and ask questions. So writing it up on the chat, and after we'll be able to read it through, and then basically, so we'll try to make a start now, hopefully. So you're through with your settings now, and you're staying on the Ukrainian channel. So that's why let's start off. And so we would like to welcome Elisabeth. So the floor is all yours.
Thank you very much for this lovely introduction, and hello and good afternoon to all of you. And today's topic will be diagnosis of bloodstream infection, catheter-associated bloodstream infection according to European case definitions. I think being an infection controller, it's quite important to, these are my conflicts of interest, so they're none, but it's very important to know about healthcare-associated infections, in particular those who are quite clearly associated with caregiving or with medical interventions. And this is, of course, central line bloodstream infection. And it's appalling that central line bloodstream infections are actually associated with a considerable attributable mortality, as shown in this first picture, to guide you into this topic. And it's really double death rate than without having any kind of bloodstream associated infection. So therefore the next minutes or the next half hour will be on how to diagnose it, how to prevent, and also how to prevent it. So I will start with definitions, because, you know, infection prevention and control is relying not only on interventions we do to prevent infections or to control infections, but also to control what has been done and what was effective or not, and how can we even find a problem which we probably don't know, and therefore we need epidemiology, and which we call surveillance. You have already heard it before, and I really want to start very basic about what is a central vascular catheter, and it's a central venous line with more than one lumen usually, and each lumen is actually referring to a separate channel within this catheter, allowing to give differential intravenous fluids, which probably, if given in one lumen together, might interact and then be worthless for the patient. And so we have to be in mind, each lumen is also at risk having being infected and therefore be the cause of infection. So the more lumen you have in the catheter, the greater the risk. On the other hand, there are quite commonly used catheters, which are actually central venous vascular catheters.
Sorry, Professor Presterl, to interrupt you. I just want to make sure I'm on the right slide. Would you be so kind as to advise me when to progress?
Excuse me, I'm going over to the next slide. This is slide. Yes, this slide. Oh, I'm sorry. I really apologize. So I have been talking about the central vascular catheters, and now there's something quite commonly used, the peripherally inserted central catheter, which is actually inserted in the cubital vein or even lower, but actually the tip is in a central vein. There are also quite really abundantly used peripheral venous catheters, the so-called PVCs. It has only one lumen, and it's usually used for patients who are unstable or need a lot of fluids. And I will not talk about implanted catheters with reservoir or port catheters, which have, of course, also a very considerable risk of infection, but usually they're used in a very selected group of patients. Here you see the catheter with the different lumens. I hope I can show you, but I can't. You see the handling of it? Quite good, well done. So next slide. So just for definition, PSI is usually, for epidemiological reason, is a laboratory confirmed bloodstream infection. So you have to have a positive blood culture with a recognized pathogen. So for instance, E. coli or Staphylococcus aureus. Or a patient has the symptoms of bloodstream infection or of sepsis, but at least fevers, chills, or hypertension, plus 2 positive blood cultures for a common skin contaminant of 2 separate blood samples, usually within 48 hours. So they shouldn't be too much apart. And skin contaminants are, of course, Coagulase negative staphylococci, the most prominent being Staphylococcus epidermidis, but also Micrococcus, Propionibacterium acnes, Bacillus, or Corynebacterium. And because we know that these catheters may be colonized and may cause infection and bloodstream infection, because these skin bacteria form a biofilm on this catheter tips or within the catheter lumens, and then may cause bacteremia. So sources of bloodstream infections, that's the next kind of definition, because we usually talk of primary bloodstream infections and of secondary bloodstream infections. It's a little bit, let's say, tricky, but primary ones have usually no focus, and the secondary have focus. But the primary also includes catheter-related BSIs. And these bloodstream infections are therefore primary ones because these catheters are within this blood vessels, so it's a primary one by definition. And if it's catheter-related, it's the same microorganism is cultured from the catheter, or symptoms improve within 48 hours after removal. So if you draw it out and the patient is well again, so you probably do not have to do anything. Besides, if you have a culture treat this the microorganism. So, and the other one is catheter-associated bloodstream infection, which is a definition by CDC NHSN definition. And it's primary BSI with a central venous catheter use, even intermittent for 48 hours. And unknown origin is if you do not have any kind of focus and the bloodstream infection, you just isolate the bacteria, the pathogens from bloodstream. Secondary BSIs to another infection usually is diagnosed then if you have a kind of infection site, the strong clinical evidence exists that the bloodstream infections actually is secondary to decide. And it's usually, if you have pulmonary or respiratory symptoms, you have symptoms. If you have pulmonary symptoms, then cough or fever or pain when breathing, then it's probably related to pneumonia. If you have urinary tract infections or digestive tract infections, surgical site infection, which maybe is not unusual in skin and soft tissue infections. So next slide. And then the next definitions, these are the European ones, which are used by CDC, are the catheter-related infections. This is, they're usually numbered 1 to 3, and 1 is a local infection. You do not have a positive blood culture, but only a culture of from the pus and inflammation from the insertion site. So you do have signs and symptoms of infection at the insertion site, but on the other hand, you can also do a culture, and you should do the culture because then you can count the colonies. It's more than 10 the power of 3 colony forming units, or if you have a semi-quantitative culture, which I'll come later, it's more than 15 colony forming units on the agar plate. And if you have the second CRI2, you have also no positive blood culture, but you have a positive quantitative culture of the catheter tip. So you're doing a quantitative culture, and then you have more than 10 the power of 3 colony forming units per ml, or semi-quantitative CVC culture of 15, more than 15 CFU, and clinical signs and symptoms improve after catheter removal. So you remove, for 2, you have to remove the catheter, and then you have CRI3, which is actually the, let's say, most commonly diagnosed as catheter-related infection that's microbiologically confirmed with a positive blood culture occurring within 48 hours before and after catheter removal, plus a positive blood culture with the same microorganism from quantitative CVC culture from greater equal to 10 the power of 3 CFU per ml, or semi-quantitative CVC culture of greater than 15 CFU on the agar plate. Or, and this is again an or, as you see, we have a lot of definitions, but this is important if you are going to do surveillance to quantify the problem of a catheter-related infection, PSA occurring with and without catheter removal, and at least one of the following quantitative blood culture ratio, which is also of CVC blood sample, peripheral blood sample greater 5. This is also a method to diagnose it. And the differential delay of positivity of blood culture, you do a CVC blood sample, and then you do also a peripheral blood sample, and then there shouldn't be, the CVC sample should be positive earlier. The positive blood culture is the same microorganism from pus from the insertion site. Why is this so complicated? Because there's so many manifestations of catheter-related infection, and if you really want to get rid of the problem, you have to find all of them. This is why it is. Next slide. So next slide, Peter. Okay, thank you. So the same relates to the peripheral venous catheter. So I'm not going to repeat it, but you just have to know that even the peripheral venous catheters are also point of entrances of bacteria into the bloodstream. So they shouldn't be neglected. They should be cared and handled like the central ones. And they may also cause severe infections, severe bacteremia, and sometimes they may also cause death. Next slide, please. So for diagnosis, and now coming to the microbiology, because I just was already hinting to it for the different possibilities of cultures. And first of all, to find a blood culture, we are the next slide, blood cultures. You have to take blood cultures, and 2 sets of blood cultures are, let's say, standard. It's usually aerobic and an anaerobic bottle. In one set, prefilled with an appropriate fluid medium obtained by venipuncture of a careful disinfection of the skin with an alcoholic skin disinfectant. It's important to allow to dry this alcoholic disinfectant, because otherwise you may get contamination by the skin flora. And next is also to draw also the appropriate amount per bottle. Usually the product is already prepared for that. So you can connect it immediately to a kind of adapter to this for blood taking. And so you do not have to think of it, and I will later on show you the picture. But for adults, it's about 10 ml per bottle. For children, it's 5 ml per bottle. So for very small children, it's very, very little, because they're very small. And for very low birth weight neonates, it's half a milliliter blood per bottle. So it's usually, you should really stick to this amount. And why can we use less quantity of blood per bottle for children? Because they have higher counts of CFU per ml blood as well. So incubation time is usually 5 to 7 days, even for fastidious microorganisms, because the fluid media within the bottles have been optimized for the last decades, and they also work for fungi, for Bartonella or Brucella. You have to allow for a longer incubation period for at least 14 to 21 days, and be aware that contaminants may be more common with the longer incubation rate. This is why we really don't take one long incubation rate for all of them. So you really have to be aware of them. And for positive blood culture during bacteremia, time to positivity usually is within 48 hours. Next slide, please. So this is pictures of a blood culture set. So you see the red one and the green one, and you can, it's hard to demonstrate, but you see a white horizontal line on the black bar, and this is how much blood has to be inserted into this bottle. And then you can see the amount. So one needs more and one needs a little bit less. And this is on the left side, and on the right side, you see the automatic blood culture systems. There are different companies who are having this kind of systems, and they are usually designed this way that these fluids, this nutrient fluids within these blood bottles have a kind of a color, a fluorescent color, which becomes fluorescent when there's growth of bacteria. So bacteria, when growing, produce metabolites, and then this fluorescent is set free, and then the machine which starts measuring kind of this fluorescent or in periodically will find when it's positive, and sometimes it's not even periodically, because they're already inserted within this measuring points. So next slide. So the next thing is, I told you about these quantitative cultures of catheters. You know, catheter, to diagnose catheter infection, you usually used to culture the catheter tip. But it's, you know, it may be contaminated when pulling it out, and so you probably have to have a very good method. And one of the, let's say, the oldest one was the quantitative culture by Prof, who recommended to use 3 centimeters of the catheter tip, and then this catheter tip is rinsed with sterile NaCl, and then it's plated to the or rolled on this fluid is rolled on fluid is plated on the agar plate. And then if there are more than 100 colonies, it's predicted for catheter-related infections together with clinical symptoms or sign. However, on the right side, you see a picture where you see it's probably not plated fluid, but it's the rolled catheter. This is done more often. This is the even more older Mackie methods. And then you have again, 3 centimeters catheter tip on hold on the agar plate. And if you have more than 15 colonies, then it's clinically relevant colonization of this catheter tip, and it's predictive for catheter-related infection together with signs and symptoms of infection. But as we have been at the definition before, both these methods are valid to do, and it depends on the microbiology lab which one is feasible to perform within the lab. And I think it's you really have to contact your laboratory and be in good contact, which you should be anyway, because getting the results as soon as possible. So next slide. So the diagnostic of the next thing is, if you sometimes as you're a clinical person, you will say, well, I don't know. Maybe the catheter, it cannot be, but it's probably not the catheter. So I do not want to pull it out because it's very hard for this patient to get another one. So you really think of some other methods. And so there's the so-called quantitative blood culture ratio published by Kilisi in 1997. And then you draw the blood via the CVC or by the peripheral vein and plate it on the agar plate. And then you count the colonies after incubation. Differential blood count is then considered positive if the ratio of central catheter and peripheral catheter is greater than 1. So this is also quite complicated, you have to have this dilution step and everything, and it's also always the fear of contamination. And the other one is quite probably the problem. The other one is the differential delay of positivity of blood cultures. So you draw blood cultures peripheral, and from the peripheral vein, you draw the blood culture from the central venous catheter. And if the blood culture of the central catheter is 2 hours earlier positive than from the peripheral side, then it's predictive for central catheter infection. And so these are, if you press the button, you will see this results from our lab. So they're in German. I apologize, and the English translation is for me the English translation is on the right side. But you can see that there's two kinds. You have the peripheral blood culture and the central blood culture, and you see it's positive after 8 hours, and for the other one, it was really took a long time to be positive. So it's certainly predictive that this Staph aureus is also on this catheter. The symptoms were sepsis, so the patient was severely ill. So next slide, please. So what are the burdens? So I think it's important after having all these definitions, because we will need them to interpret all these publications and of the PSI and of catheter-related infection and sepsis. And first of all, the burden of sepsis is quite considerable, given it's calculated in the population. It's differential in different regions, and this is actually the global report of the epidemiology and burden of sepsis. And as we know, that catheter-related bacteremia and sepsis are pulled together in these publications. So you really have to be in mind that it occurs everywhere. Next slide. Next slide. Okay. So for systemic infection, I have to remind you, I think you now know all about catheter-related infections, but for sepsis, it's a little bit more than having positive blood cultures. So we know if the blood culture is positive, but we have also patients who do not have a positive blood culture. And for epidemiological reasons, I also have to introduce you to other definitions, which are in the below area of the slide, the indication of antimicrobial treatment, for instance, in our ECDs, prevalence studies. And so you have the clinical sepsis, where you only have signs and symptoms of bloodstream infection and where you do not have already a positive blood culture. And then there's also febrile neutropenia, and there's also the so-called CIRS, the systemic inflammatory response syndrome without clear anatomical side. But all these may be also subsumized within sepsis. And if you go above for HI, you probably have some kind of definition like disseminated infection, again with signs of symptom of infection, or you have probably something kind of CSEP, which is also kind of sepsis, which is not treated unidentified. All this refer to systemic infection, probably and definitely caused by bloodstream infection. Next one, please. So for sepsis, I think you have already had a talk, but I just refer you back to the clinical definition, which is within the hospital, there are life-threatening organ failure, and the SOFA score, this sequential sepsis-related organ failure assessment score of 2 points or more caused by dysregulated host response. And out of hospital, there's a quick SOFA because you don't have a very sophisticated lab, and it's usually the patient is strange, altered mental state, respiratory rate greater than 22 per minute, so even greater, and a low systolic blood pressure of 100 millimeter quicksilver or less. Next one, please. So, and all this, if you want to prevent it, if you want to control it, make it visible. So surveillance and epidemiology, after having all these definitions, is pivotal to do. Next one. So, and I just, next, please press the button. So this is very nice study. It's a study showing that the reduction of catheter-related bacteremia was already starting when starting the surveillance. And this one is a study on MRSA bacteremia. And you can see you started surveillance, but you did not do any intervention yet. And this is very important because you know if people see that you count something and you can show to them, then they will understand the problem. Very important. Next one. Next slide, please. And if you go for whole Europe, what is the burden of these healthcare-related infections, and then then later on, or including bloodstream infections or catheter-related infections, we started to have European point prevalence studies in 2010, 2012, and then 2016, 2017, and quite recently to include all countries, so most of the countries all over Europe. And you can see the green ones, those who have been taking part into these studies, and the gray ones not. And I think it's very good to see to have comparable results, and therefore it's also important to have this definition. And you can see this study comprised about 325,000 patients of about 1,200 300 hospitals, and the peripheral catheter carriage was about in 50%, 48.7% of patients, and the central catheters were of course much less used, only in 7.5% of the patients, but there's also quite a variation between countries. And this is of course also interesting to know how catheters are used. So they may be much higher also in certain hospitals, and overall the infection rate of HI was 5.5%. Next one, please. And if you go to the bloodstream infection, and then you can have a look at the patients. So you have overall 18,286 HIs, healthcare-associated infections, and about 10% are bloodstream infection, and another 1.2% are catheter-related infection without bloodstream infection. So bloodstream infections here are already including catheter-related infections, and type 3, of course, because then you have a positive blood culture. And if you take the later below the systemic infections, which might be also systemic infection, caused bloodstream infection, you have another 5.4%. And you know, so it's really the fourth most common infection in hospitals. Next one. So to see how central venous catheters are used, it's very, you can also make a nice picture, and then you can see how much it is used in what countries, in which countries, and you see then you probably have a high use of central venous catheters in Italy or in Greece or even in Spain, and also in Austria. But it also depends which hospitals have been participating in the study. But you really can then probably have more clarity about what's going, how is the use and what is to expect. If you have a high use, you probably you will not have a higher rate, but you will have more infections. So next one. And if you go for peripheral venous catheter, so it's really common because many patients come to the hospital and get a peripheral catheter for intravenous fluid. And it's also a lot of burden of these infections. It's not a burden, but we do not know the burden because the actually infection rate of peripheral venous catheter is not very high. And I think it's also due to you are not sending in these catheter tips. Next one. So what is now the frequency of catheter-related infections is the total of all HIs. So this is the percentage of the HIs. And you see it's, of course, not correlating with the use of CVC or of PVC. But you see that certain countries like Spain, Greece, but Italy, but also Austria, Hungary, they have a quite infection rate above 4%, which is high, but it may be also that many hospitals taking part in this PPS are probably at least a tertiary care center or secondary care centers who have intensive care units. Next one, please. If you go for antibiotic treatment, this is also a feature of PPS. When patients are included into the study, they will be either rated by having not either. You just take the infection, is the infection present, it's a HAI, or do they get antibiotics? And then if you take the group having antibiotics out of the whole population, then it's about 1/3 of them using it, you know, and then you will see then these patients will get it, and here you have CI, HI, LI, and this is community-acquired infections, and these are all systemic infection, and these patients already come in, and then have a little estimate on the burden, which is on what kind of bacteremia or systemic infection are coming from outside. So it's not so low. It's about 12% of the patients from coming in, and it's of course higher antibiotic use for HIs. It's because the number is lower, and also from healthcare, from long-term care facilities. So please, the next one. So, and where do you find the patients with bacteremia? So you can see bacteremia is the purple one, and the systemic infection is the blue one. And you can see bacteremia is, already this is the defined, by definition, the microbiologically confirmed bloodstream infection. So you have a pathogen, but you will find it more often in intensive care, but also in pediatrics and in medicine and sometimes in surgery. And systemic infections you find obviously more in babies, but also in pediatrics, where you probably don't take so many blood cultures. So next one. And of course, you will ask now, what are the major pathogens of PSI in this study, in this European prevalence study from 2016 to 2017? And you see the most common isolated bacteria were Coagulase negative staphylococci, and these Coagulase negative cocci are presumably also those which cause catheter-related bacteremia. And of course, there's also Staphylococcus aureus and Escherichia coli, which are the most common pathogens isolated from blood cultures, followed by Enterococci, Klebsiella, and Pseudomonas, but also fungi like Candida. And there's a few Acinetobacter, but given the whole patient population, it's quite considerable numbers. So next one, please. So infection prevention and control. So after illustrating the burden, I have to talk about how can we prevent these infections. Next one. So we know, again, back to make it visible. Bloodstream infections, HI, bacteremia, catheter-related infection, you see that from total PSI catheter-related infections are 700, and from central venous catheter it's 600, and you can see it's considerable numbers given the whole population. And of PSI with unknown origin, it's also quite numbers and unknown origin. But anyway, you know that catheters may be a problem and are related to infection. This is important to see and important to accept. And you see that, of course, catheter-related infections due to central venous catheter are more common than those ones from peripheral venous catheters. Next one. So why, and this is why is this infection? And I think this is a very, very lovely picture out from the publication in 2023, because it shows you how can you prevent infection and also where infection may occur. We have already learned that lamens, the different of the catheter may play a role, but also the handling and the insertion site. And as you can see, the catheter may be contaminated at the insertion site, and then there you have a lovely dressing where you can see the insertion site. The infection may also occur also within the lumen. So these pathogens can migrate or are brought by the infusions within this catheter lumen, and then they may accumulate, and probably also it may also be colonized backwards by a secondary to infection. This is also possible. So the catheter tips within the bloodstream become colonized with the initial bloodstream infection, and the third one is, of course, contaminated infusate. And all this is, you have to be in mind, particularly the handling of the catheter, the dressing and the insertion of the catheter, but also the handling of the of infusions and so on, are very important for infection prevention. Next one, please. So risk factors, these are also from these publications. This, of course, patient factors. This is immunocompromised, neutropenia, burns, malnutrition, BMI greater than 40, prolonged hospitalization before a catheter insertion, premature of infants, or limited venous access. But also the setting and structure. If you have to insert the catheter within emergency, you probably do not have the time for waiting to dry the disinfectant, or if they could not did not adhere to the aseptic insertion technique, multiple manipulation of the catheter. So the often it's used, the more chances, the more risk for infection. Then also low nurse to patient ratio, so it's staff shortage or failure to remove the unnecessary catheter. And I think this is the first thing we all have to think remove as soon as possible. And device factors, of course, catheter material, the insertion site, if it's subclavial or femoral, and indications for use. So you really have to rethink the indications, and it must be a quite good indication because it may do harm. Next slide. So there's also a very old publication on what's the efficacy of nosocomial infection control. You see it's also the old term, and you see bloodstream infection is reduced by 35% if infection control procedures are handled, properly handled. Next slide. And how can we prevent this catheter-related infections, particularly the catheter-related bacteremia? And first of all, for hygiene, you have to have checklists. You have SOPs, standard operating procedures, how to insert the aseptic catheter. The next one, how to handle the catheter. So clearly, point by point, lists how to handle it and also train it by this. Catheter insertion part or kit, you have a preparation. If you insert the catheter, you have prepared for all, so probably you do it not well doing it, but before, and it's even easier, you have already a kit where everything is packed in sterile covering, and you have all things together. Hand hygiene is pivotal. Then sterile perio precautions and gloves and gowns, and then alcoholic chlorhexidine skin antisepsis helps as well. Then catheter site material and care, selection of the insertion site where you have least infection, so for instance, subclavian. Then you have probably dressings with chlorhexidine, then chlorhexidine bathing. For longer catheter use, you may consider antibiotic or antiseptic impregnated catheters. And when handling the catheter, manual decontamination of catheter hubs and caps before catheter insertion. And maybe also the use of antiseptic containing cups. So everything which decreases bacterial colonization will help the catheter-related infection, to prevent the catheter-related infection. Next one. So the next one is also a very lovely study actually on catheter-related, central venous catheter-related bloodstream infection, also on hand hygiene and on all these bundles for aseptic insertion and so on. And you can really see very, very nicely, so there was a big European crossover study, and with different hospitals, and those one was starting with high infection rates, of course, had a very significant decrease, and the other ones having already quite low infection rates. They, of course, conserved the low infection rates, but you can see they had 3 interventions. One was this comprehensive catheter insertion strategy, so having preparation of items, a kit or a sterile card, a sterile insertion, assistance, safe C/C manipulation, dressing change. Then the second one's only the normal insertion of the catheter, which was normal in their hospital, so no other. Then only hand hygiene, and both combined. And they both combined are the blue ones in the upper figure. And you can see if the combination worked very, very well, but also hand hygiene was working very well. This the black one. And this really see that doing all of them, it's of course most effective, but also hand hygiene has its proper role. Next one. So this leads us to alcoholic hand consumption. We know that the day of hand hygiene is arriving with the 5th of May, and you see that there are some countries who are leading in it and sometimes in the middle, but we have this maybe not, but it's essential to be monitored and particularly for training reasons for all of you people to get their hand disinfected. Next one. So, and I just have to remind all the intensive care specialists who have been working there for many, many years, or already nearly 20 years ago, it was shown that bundles, full area precautions, chlorhexidine and they say sterile insertion of the central catheter is very effective in reducing the catheter-related bacteremia. So it's known for a long time. We know it, and we still have to be in mind to fight it because it's still there, and so we still have to talk on it and work on it that catheters are not the source of severe infection for the patients. Next one. So these are the standard operating procedures. So every hospital has got, next one, please. The standard operating procedures for insertion and handling of the central venous catheters. So this is only the major parts of it. So this is ours. It's translated in English or in Ukrainian. It's in our, this is our link to our infection control map, how to SOPs, how we do it. And you can see it's very important that you know the catheters, the proposed use, the standard handling, pay attention to the careful preparation for insertion and for the catheter maintenance. And but if you do this standard operative procedure for your hospital, please describe each step very carefully. So even for the catheter hub, for the catheter insertion site, inspection and dressing, and what to do if infection is suspected. All this should be given in a SOP or even more than one. But it's important to have it on the board so people can do a kind of checklist what to do and how to handle and how to react if there's infection of the catheter suspected. Next one. So how to prevent sepsis, it's infection prevention and control on the first part. And I have to remind on that if you have no infection, you will not have sepsis, and then you will have successful healthcare. And the next slide is, I think, my last one. Yes, it's the summary. It's still a considerable use of morbidity and mortality in patients, particularly bacteremia, but also catheter-related bacteremia, catheter central line associated bloodstream infection, both of them. Appropriate diagnostic should be performed routinely. Prevention is pivotal for insertion and handling. But the most important prevention intervention is remove as soon as possible and really consider why do I need a central venous catheter. Please remove catheters just to stay there for convenience of blood taking. It's probably not, it's sometimes feasible, but it should not be routine. So this is my last slide. Thank you very much for listening, and I'm happy to take your questions. Okay, no, it's not my last slide, but it says the same.
Дуже дякую, пані Presterl.
Thank you very much, Professor. Thank you very much indeed. And I see everyone thanking you in the chat, and we have the questions now available. Question number one was, how do you select what antimicrobials you need for empiric treatment for BSI?
So I think this is a tricky question but you usually know that bloodstream infections or catheter-related bloodstream infections are by skin conventions, and you have to look at the patient, and of course you have to have also think, when do I have to treat him? So we know that if it's a catheter-related infection, you just pull out the infection, the catheter, and then you can probably wait if the patient is unstable. If you don't know anything, the patient is septic, you probably have to cover as well gram-positive and gram-negative bacteria, depending on the state of the patient. So you have a broad-spectrum antibiotic. This is always a tricky choice, and it's always also dependent on your epidemiology of pathogens which are around. So it's usually most common ones are E. coli and Staphylococcus aureus, and so it should cover these two bugs.
Дуже дякую, професоре Presterl.
Thank you very much, Professor Presterl. Well, let me kindly remind, dear colleagues, how important it is really to collect the local epidemiological and microbiological data to understand what you have as a result of your culture testing. One more question, if I may. Did you come across Rhizobium radiobacter among Klapsi? They say it was isolated from the port of the catheter several times from different patients.
Yes, I've heard about it, but no, not in our institution, no.
Добре, дякую.
Thank you very much. Indeed. One more question. What is your attitude to a so-called antimicrobial lock? This is when after a certain manipulation with a catheter, you inject a certain part, a certain portion of antibiotic, and then you close the catheter.
Yeah, I know. We used to work on that, and I think books are still not closed about it, but it may, you know, sometimes you do not want to pull out the catheter, you know, and there you probably also suspect there may be a colonization of this catheter, and so it might be a good, it will may be an option to do it. And of course, there are several ways to do it, it's true, but to do it routinely for normally use catheters, I don't think it's a good idea. I think you should really stick to handle and care for the catheter carefully for infusions, for with the dressings, and I think this is the first thing you should do, not the antimicrobial lock.
Ще в нас наступне запитання.
Thank you very much. One more question. Are all catheters from the intensive care unit need to be collected for further culturing?
Well, this is a very tricky question. If you want to make a, if you really want to make good surveillance, or probably initial ones of what is going on an intensive care for a certain period, yes, so you have a, let's say, a starting point, how many are colonized or how many are really infected, then you probably do it. Usually you don't do it because you just pull out the catheters that the patient does not have any signs or symptoms, neither locally nor systemically, you don't culture them. But if the patient has a fever, kind of infection, if it's there's redness in the insertion site, you of course can have to send it in. And you should also draw blood cultures as well together with the catheter tips, because otherwise you will not. There's very hard to say something about it. And if you have systemic signs as well.
Дуже дякую за відповідь. В нас є
Thank you very much indeed. One more rather comprehensive question. Who of the staff is supposed to insert the central catheter, and what chlorhexidine solution do you use for skin treatment? And the continuation of that is, who pays the further treatment of CLABSI cases?
It's I just have to recapitulate. So who is going to insert the catheters? You mean it's not so much who, but which department or the patients are not doing, you are not doing it but usually it's, of course, the doctors are inserting the catheters. In our institution, it's done by intensive care. And the chlorhexidine bathing, they are commercial ones and they're 2% or whatever, but they're commercial ones for skin use, and you use the best use these ones. And who pays for it? So it depends how you are how it's let's say that the financial things are negotiated within your hospital. So in our hospital, they are officially transferred to another department. So, but there's an overall coverage. So there's no question about it. But this is something which you have to negotiate. And the infection, of course, you have to treat them. And it's in Austria, it's quite an infection in the hospital. So it's included in treatment, of course.
Дуже дякую, пані професор, за відповідь.
Thank you very much, Professor, for this answer. Let me add on my behalf just a bit. According to the guidelines for skin treatment, it is recommended to use the 2% chlorhexidine solution, just for the general audience. Let me continue with a bit of more questions. When taking care of the intravessel catheters, is it allowed, and if you use the heparin solution?
Now I cannot really follow you. What can you describe a little bit more?
Під час догляду за
Let me reiterate. During catheter care, do you use the so-called heparin-based
I see.
stoppers?
Yes, we use them. Yes, but not let's say routine. Usually we rinse the catheter with saline, and usually catheters are used also because they're there for continuous infusion. So you cannot use so much, but you can use it if you're. But it's not, let's say, generally recommended. You have to know if there's, let's say, more problem with thrombotics, so on. Because it was quite common years ago, yes. But the most important is rinse with saline.
Дуже дякую, пані професор. Я бачу,
Thank you very much, Professor. Well, I see we are running out of time. So the last two questions, if I may. So in your country, how do you collect data about Associated information prevalence in your hospital?
Oh, yes. You see, in our country, there's a recommendation by the Minister of Health to collect data on infections in the intensive care units. This is part of their quality program. So they have to collect them. And so for intensive care units, they have also to collect the data on CLAPSIs or CRI or whatever. And also they denominate the data, so the device days as well. And this is, and for prevalence, we do the prevalence the prevalence studies we do now every second year for hospitals, which is organized centrally. So it's voluntary, I have to say, but it's very, very nice to see that there are different hospitals participating at this prevalence studies. And this is organized centrally by the National Reference Center, but it's done by the local infection control teams who are trained and who are actually collecting the data, and which are then sent to the database of the National Reference Center.
Дуже дякуємо за відповідь.
Thank you very much. And the last question, if I may, because we are running out of time. I actually really hope we're going to be able to provide you, dear colleagues, with answers to the other questions. The last question is about the piece of your presentation. It was mentioned that metroponia is a risk factor for CLAPSI development. Could you please indicate what level of that is considered to be dangerous?
Well, I think neutropenia per se is a risk factor for acquiring infection. I think, and if you go all through the data also for CLABSI or catheter-related infection, in the big studies, you will, of course, always find a significant significance with neutropenia. So, of course, you have to handle these patients with particular care. And you know that these patients usually have central venous catheters because they need it because of chemotherapy. If the I'm just thinking of the leukemia patients who are particularly at risk and they need the central venous catheter. So you have to be very, very careful handling and caring for these catheters. And for let's say short time neutropenia, probably the data are not, they're actually just saying neutropenia, so you can imagine.
Дуже дякую, професоре Престерель.
Thank you very much, Professor Presterl. Thank you very much for your wonderful presentation. We have lots of words of gratitude on the chat box to your presentation. It was very informative. Thank you very much indeed for this beautiful presentation. I'm very grateful for your presentation, for your speech. I'm also grateful to other colleagues, ICAP, ECDC, American CDC, and EU KIC colleagues for making it possible to organize such important events for Ukraine. Colleagues, let me inform you that we continue our cycle of webinars to ensure proper training and education to the specialists of infections and preventions and for IPC specialists. So please follow our website and also YouTube channel of the Ukrainian Public Health Center. Please follow the new announcements to follow. I'm very thankful to you, dear colleagues, and to you, dear Professor Presterl. Thank you very much.
Thank you.